So good morning all. Today we will discuss a topic that is angina. So basically what is angina? Angina is a type of a chest pain caused by the reduced blood flow to the heart. This reduced blood flow, it is due to the deposition of a plaque, or it is due to the atherosclerosis, or there are many other factors which trigger the angina. So basically, in what happen in angina there is a type of a chest pain. This chest pain is occur due to the reduced blood flow to the heart. So basically, there are three types of the angina. First one is stable angina, second is unstable, and the third one is known as variant or a vasospastic angina. So what happen in the stable one? There is a deposition of a plaque in the stable angina, and in the unstable angina the deposit plaque is get ruptured, and in the vasospastic or a variant angina there is a vasoconstriction of the main coronary arteries. So so this constriction of the main coronary artery will trigger the vasospastic angina. So suppose person is normal and doing a physical exercise. During the after the physical exercise, he or she might be have a chest pain. So this type of angina is called a stable angina. After settling down, the patient will not feel any chest pain. So it is a type of a stable one. So these are the management for the stable and the unstable angina, and these are for the vasospastic angina. So what happen? So in the stable angina, we can decrease the work on the heart. We can increase the blood supply to the heart, or in the variant or the vasospastic angina, we can dilate the main coronary artery, so get angina get be reduced. So this is a pathophysiology of the angina. Basically, oxygen demand and oxygen supply will be proper balance towards our heart. So what happen in angina? In angina, the oxygen demand get more and more increased, and the oxygen supply is more and more get reduced. So these are the drugs which are used in the treatment of the angina. So first one is nitrate. In nitrate, we use glyceryl trinitrate, isosorbide dinitrate, isosorbide mononitrate, and amyl nitrate, and so on. Then second one is CCB, that is calcium channel blockers. So in this we use verapamil, diltiazem, dihydropyridines drugs. So third one is beta blocker like metoprolol, propranolol, and so on. And fourth one is potassium channel opener. It includes nicorandil. Fifth one is other drugs like trimetazidine, ronaldine. So these are the drugs which are used for the management of the angina. So let's get started one by one these drugs. So first one is nitrates. So nitrates are mainly cause the are mainly the venodilators, means they only do the dilation of the veins, but they also cause the dilation of the arteries, so they are also a arteriolar dilators. So both veno and arterial dilator, they will cause the reduce in the preload and the afterload. So so the nitrate will reduce the both the preload and the afterloads, but more they will reduce the preload as compared to the afterload. Then the mechanism of action of nitrate. Then what nitrate will do? When we take the nitrate, then there will be a increase the formation of a nitric oxide in our body. This nitric oxide will increase the cyclic GMP formation, and this cyclic GMP do the dephosphorylation of the myosin light chain, and this will cause the vasodilation, means relaxation of the vascular smooth muscles. So these are the mechanism of action of nitrates. So these are the 5 drugs in the nitrates which are used for the management of angina. First one is glyceryl trinitrate, second isosorbide dinitrate, third isosorbide mononitrate, then pentaerythritol tetranitrate, then amine nitrate. So remember guys, you have to remember this thing that glyceryl trinitrate and isosorbide dinitrate are used by sublingual route because this both drug have high first pass metabolism. Both this drug, that is glyceryl trinitrate and isosorbide dinitrate, have high first pass metabolism, so they use by sublingual route. So third drug is isosorbide mononitrate. It does not have high first pass metabolism, so it cannot be used by sublingual route. So second one, next drug is pentaerythritol tetranitrate. This drug is the longest acting nitrate. Fifth one is amyl nitrate. This drug is the shortest acting nitrate. So these are the five drugs in the nitrate category. So next is nitrate will develop tolerance. So we have to keep the nitrate free period every day, that is 7 to 9 hours. So next one is drug interaction. So this is very important from any exam point of view, that nitrates and phosphodiesterase inhibitor like sildenafil citrate never be given uh, together with the nitrates. So what happened previously, we will discuss the mechanism of action of nitrates. The nitrates will release the nitric oxide, which will cause the increase of cyclic GMP, and then there will be a vasodilation. So after the vasodilation, this cyclic GMP get demolished or get destroyed by the phosphodiesterase. So there is a drug like sildenafil citrate, which is a phosphodiesterase inhibitor. If this phosphodiesterase get inhibited, then this cyclic GMP action get more enhanced. So there is a chance of a more hypotension. So never nitrates and sildenafil given together to a same patient. So next we are discussing the calcium channel blockers. So in this category, drugs include verapamil, diltiazem, dihydropyridine analog. It will include nifedipine, amlodipine, and clevidipine. So the mechanism of action of CCB, that is calcium channel blockers, include it will reduce the transmembrane flux of the calcium. So when transmembrane flux of calcium will reduce, so then there will be a negative chronotropic effect, and then there will be a negative inotropic as well, and then there is a smooth muscle relaxation. Then therefore after the smooth muscle relaxation, then there will be decrease in the myocardial oxygen consumption. So both the drug, that is verapamil and diltiazem, cause the vasodilation by decreasing the preload and afterload. Therefore, they will decrease the work on the heart. Next is the verapamil causes the constipation and the ankle edema as a side effect. So, and the next drug, that is nifedipine. Nifedipine causes the hyperglycemia by decrease the insulin release. So the calcium channel blocker drugs like verapamil and diltiazem, these drugs are used both in the classical and the variant angina. So next drug is beta blockers. So in this group of drug include metoprolol, carvedilol, and so others. So the main point here is beta blockers are contraindicated in variant angina. Beta blockers are always used in the classical or the stable angina. See why beta blockers are contraindicated in the variant angina, because what happened in the variant angina, the coronary arteries that is present, it already get constricted. So if we block the beta 2 receptors which cause the dilation of the coronary arteries, so if we block them, then there will be too much vasoconstriction here. So we want vasodilation, not vasoconstriction. So this is the reason beta blockers are not used in the variant angina. It is contraindicated. It is only used in classical or the stable angina. Next, the mechanism of action of beta blockers is it will decrease the workload on the heart. Basically, metoprolol or carvedilol drugs, it will block the beta 1 receptors, so therefore decreasing the heart rate and the force of myocardial contraction. Then there will be a decrease in cardiac work, and there will be decrease in myocardial oxygen consumption. So this is about the beta blockers drug. Next, see, calcium channel blockers used for both classical and the variant angina, whereas beta blockers only used for the classical angina, not for the variant angina. Next is potassium channel blockers. In this drug include nicorandil. This drug nicorandil, it will cause the coronary dilation by the opening of the potassium channel. It has one additional property, that it will release the NO, that is nitric oxide. So when it get released, there will be a it will cause the vasodilation. So the adverse effect of nicorandil include hypotension, headache, buccal and GI ulcers. Next drug is trimetazidine. So in this drug will, the mechanism of action of this drug is it will metabolic shift from fatty acid to glycolytic metabolism. See what this drug will do. Our heart will use fatty acid as a fuel. So this drug will switch the fatty acid to glucose. So then our heart will use glucose as a fuel. When our heart use fatty acid as a fuel, then there will be generation of a free radical. When our heart use glucose as a free radical, then there will be no generation of a free radical. This free radical are cause the damage to our myocardium, but here there is a no generation of a free radical, so our myocardium will be safe. So this is the mechanism of this drug trimetazidine. Next drug is ronaldine. So this drug will inhibit the late sodium and the other cardiac ion currents. So this is a first line drug for used in the chronic angina. And the ranolazine, this drug is safe to use with sildenafil like drugs, and it cause the side effect of this drug is it will cause the QT prolongation. So next drug is ivabradine. So the mechanism of action of ivabradine include it will decrease the heart rate by inhibiting the HCN current in SA node, and it is a second drug of choice for the in the prevention of exertional angina. So side effect of this drug include bradycardia, QT prolongation and atrial fibrillation. So that's it for angina. You can refer Goodman and Gilman for more details. Thank you.